All right, so we'll get started here, and hopefully a few more folks will log on. But first off, I want to thank everybody for joining us for tonight's talk by Dr. Mike Nystrom, presented by the Vets Pets at Points East Wilson. Everyone, you'll get your CE credit in your email within about a week of tonight's completion. And a little bit about Dr. Nystrom. He's a local fellow born in Durham, spent most of his childhood over in the Cary area before going off to vet school, UT Knoxville, spending some time up at Tufts for internship, and then back to UT Knoxville for a 3-year residency in critical care. Interesting fun fact about Mike Nystrom is his scrubs, there's too many letters, so he can't put any commas between his extra letters there. So that's a fun fact about Mike. And he's a good guy. Like working with him a lot. Pretty smart most of the time. So he's going to give us a chat about CPR this evening. Hopefully you don't have to use this information too often, but hopefully he can help increase our odds of getting a few more back. So if you have any questions throughout the chat, we will utilize the chat function, which will be on the bottom of your screen. We're not going to use the Q&A function. We're going to use the chat function. So I'll keep an eye on that, and if any questions come up, we'll kind of address them as they come. So again, remember that chat function, not the Q&A function. So without further ado, here's Dr. Mike Nystrom, and we're going to talk about cardiopulmonary resuscitation.
All right. Thanks, Dr. Brady. I appreciate it. And thank you to everyone that has logged in. Get on your phones, send text messages. Let's get more people in here. I'm trying to beat numbers from a previous colleague, so the more I get, the better. Help me out here, guys. So near and dear to every criticalist heart, talking about CPR. It's certainly something that no matter what we do in veterinary medicine will always make me, as an individual working exclusively in critical care, feel inadequate. No matter what I do, I go into a CPR session thinking, there's no way we're going to get this animal back. And it's usually by the umpteenth minute when I'm calling it quits, and all of a sudden that heart rate spikes back up and we get to celebrate that we had success, which is really exciting, but then also comes down to, oh shoot, now what are we gonna do? So I'll tap on that a little bit at the end, but for the most part, we'll talk mostly about the CPR aspect, the actual actions during everything, what we can do, how we can do it maybe a little bit better, and then give you guys some pointers to help you along the process. Hopefully it's not something that you guys run into a whole lot, but certainly something that I'm sure throughout everyone's career we'll see at least one time or two. So without further ado, Dr. Brady, thank you for the introduction. He kind of hit on everything that I would say. So I'm a local boy, grew up in Cary, which sometimes I shake my head at. But ended up going to Tennessee for vet school and had a great time there. My wife is a veterinary technician that did anesthesia there. So I was always down in the clinic, fell in love with just working down in the clinic. Ended up doing my rotating internship at Tufts in Massachusetts. Very cold, very great experience, especially from an emergency standpoint. Came back down to Tennessee for another 4 years, actually, 3 years of residency. But before I did that, I did a 1-year critical care internship there. So a lot of time at Tennessee. I love the hospital, love it to death, love Knoxville. So glad to come back home though. I've been back home now for about almost 4 years now. And it's so good to be back to this area. I absolutely love it. I've been working at Points East, Vet Specialty Hospital in Wilson for probably about the past close to about 2 years now. Actually a year and a half, sorry. And have really enjoyed my time there, working with Dr. Brady, working with all the ER team there. Just have loved watching that hospital grow to the point that now we're busting out the seams. So hopefully we'll move to something new and bigger soon. But anyways, so we'll go ahead and talk about CPR. A little bit of kind of what to expect. Come on, presentation. Oh, there we go. Finally got it to kick in. A little overview of what we'll talk about. We'll talk about recover. And if anybody's had CPR training, the recover is kind of the gold standard for what we talk about. And we'll talk about what recover means and its importance. And we'll talk about a number of aspects of the recover guidelines in particular. Mostly I'll touch on preparedness and recognition. Then we'll touch on the big categories of life support, basic life support, advanced life support. Some monitoring that we can do during CPR, what's useful and not. And then last, we'll touch a little bit on post-cardiac arrest and kind of go through there. But hopefully, if you guys have any questions, again, along the way, use the chat function at the top. Dr. Brady will keep an eye on that. I'll try to answer them throughout. We're also going to have a few polls. So hopefully you guys can participate, and that'll give me an opportunity to take a breath and also check out any kind of questions that we might have missed on the chat function. All right. So the most number one important thing to remember when dealing with an animal that you're about to do CPR on, they are already dead. There is nothing that you can do to make them less dead. All right. Or make them more dead. I apologize. Make them more dead. So no matter what you do, no matter how bad you botch CPR, they will not be more dead. So take a deep breath because they are dead. My keyboard's being very slow. So you can't make them more dead. Take a deep breath. Hopefully between any training that you've gotten before now and this will help kind of get your means about you, and you'll have the information that you need to move forward. And I tell students this in vet school. I tell the doctors this. I tell the technicians this. And it's one of the most important things to remember. Whenever I'm doing CPR, at this point, unfortunately, because I've done it enough, I don't get the butterflies except for when I'm in the OR. And that's just because I am out of control. I'm not in the control situation in the OR like I am out in our treatment area. So take a deep breath, gather yourself, and then get going into things. All right, so a little bit about Recover. So this is an initiative that was put out by a number of specialists, but Recover essentially is an acronym, and I'm not sure how they come up with these acronyms. It always makes no sense at all. But so the Reassessment Campaign on Veterinary Resuscitation, and they just chose some few words or few letters from each word that got them Recover. It was originally put out because we had nothing in veterinary medicine to sit here and say, hey, this is our Bible, this is our flow sheet on how to do CPR. And so what they did was they gathered a bunch of specialists from a number of different specialties, but mostly critical care, but also internal medicine, some neurology. And then they also had some input from the human side. So ILCOR, I forget what it stands for. It's humans love their acronyms as well. So I just don't choose to remember them, so sorry. But human side to give input from there as well. And they evaluated hundreds and hundreds of journal articles and studies, both from human medicine and from veterinary patients. And remember that a lot of the human medicine stuff is using actually dogs and cats and mice and other mammalian species that are non-human. So a lot of the stuff that they've developed comes from those aspects, or a lot of the recommendations. It was originally published in 2012. They had a goal to revisit it every 5 years. We're now in 2022, and we have not had a second Recover phase that has come out yet. They are currently in the process of working through that right now. There's been calls for specialists to kind of help out with that. I bet we're probably still at least 2 years from a new publication on this. So lots of this stuff is somewhat old recommendations. There are some newer recommendations on the human side. AHA is the group that does it on the human side, American Heart Association. And you can find their recommendations. Veterinary medicine is very, very similar with regards to the recommendations. So I'll hint at a little bit of those things just to express some differences. But for the most part, I follow the AHA/Recover guidelines. All right, so why is this such a big deal? Why do we care about doing CPR? I mean, we're probably not seeing it very much. The last time I saw CPR at Points East, it's probably 2 weeks ago. So if I'm not seeing it very often, you guys, I'm assuming, would see it even less. It's a big deal because ultimately less than 6% of our animals that we do CPR on will survive and survive to discharge. And that's the key. We might be able to get them back, but that doesn't mean that they leave the hospital. And 6% is terrible numbers. Whenever I talk with owners of very sick animals that I've got hospitalized and they've elected to do CPR on their animals, let's say a sick DK that's down and out, I'm having troubles with the blood pressure. And I talk with them, I'm just like, do you still want to do CPR on your pet? And they're just like, yeah, it's going to be great. They're going to survive. And I'm just like, let's talk about the percentages here. You know, the sicker they are, the less that percentage comes down. The bigger they are, the lower that percentage as well. Cats maybe range somewhere up around 8 or 9% because they're smaller. We can be a little bit more efficient with doing our compressions that we do. Large dogs, let's say like a Great Dane, Labrador to Great Dane size, we're even smaller than that, or smaller success rate than that. It's probably closer to 4 or 5% really. So unfortunately not fantastic at it. Anesthetic related arrests are the best situation for us to get success. And I have had great success with arrests related to anesthesia. And ultimately, it's due to a number of causes, most of them being that it was probably us that did the effects on the body that led to them arresting. And also, we've already got them intubated. Hopefully, we've already got an IV catheter in there. And lastly, hopefully, we're already monitoring. So we can probably intervene a little bit sooner than that animal that we walk by the cage and happen to see, oh, snap, Fluffy is now dead. And we're 2, 3, 4 minutes already in the hole because we didn't look at Fluffy for the past 10 minutes, because that's just ultimately how it goes. We can't stand over top of a cage at all times for that. All right, human rates, a bit better. So in humans, they talk about rates as high as about 40%. And these are in-hospital arrest rates. Out-of-hospital arrest rates for humans, the success rate of CPR and survival to discharge is probably closer to somewhere between 10 to 20% roughly. But still, out of hospital, a bystander doing CPR, 10 to 20% seems pretty great compared to our 6% of in-hospital, with hopefully some degree of medical training with us compared to a bystander in humans. But I think a lot of it has to do with humans arrest for different reasons than many of our veterinary patients do. All right, so quick poll here. How many of you guys have had success with doing CPR? So I've had success and they've survived a discharge, being the key there. I can count them on a single hand, so less than 5, more than 5, still trying and working on that one, or not had the chance yet. And just as a reminder, get on your phones and text your friends to get them in here for me. All right, let's see what you guys got. Oh, so a single hand, that's fantastic. Oh, one person, more than 5 times. That's amazing. Congratulations. Pat yourself on the back. Pat yourself on the back for just having any time that you can account that you had an animal survive to discharge. Keep up the good work with the trying, and then 2 people not had a chance yet. I'm glad you guys are doing something right. It's probably a better thing to say I haven't had a chance yet, because that means that you've done a great job with preventing it, preventing an animal from getting there. But keep up the good work. I'm trying to think if I had to count how many I've had success with in my between my critical care training and afterwards, I've probably had success in survival to discharge on probably about a dozen or so animals, and that's almost 8 years of practicing in critical care. So my success rates are very limited as well. So I'm with you guys on that one. All right. So ultimately, we got to talk about what the goal is of CPR. And we keep talking about survival to discharge, but even before that, what do we consider a successful CPR? And that goal is what we call return of spontaneous circulation, or ROSC. Some people will try to actually pronounce ROSC as like ROSC or stuff like that. Ultimately, it doesn't really matter. This is just our fancy way of saying, hey, we've got the heart beating again. It's perfusing the tissues. Hey, we're in a good spot. Ultimately, it doesn't mean that they have complete consciousness and that they're okay up here in the brain, because many of them are not, especially immediately following CPR. It doesn't mean that they're breathing on their own. It just means that we've got the heart beating and we've got perfusion to tissues. Many of these patients will require other things after, like mechanical ventilation potentially. Someone will have neurologic dysfunction for short periods of time. Hopefully that's transient. Many of them will require some type of fluid therapy or vasopressor therapy to help with their blood pressure as well. But getting that heart beating and getting stuff circulating around is the big key, and that's the goal of CPR. All right, so when we talk about the recovery guidelines, back to this, there are 7 components to this. We're not going to go through all of them because they are not very exciting and fun. We'll just talk about the big number 7, which is the clinical guidelines. And within the clinical guidelines, so if you were to choose one aspect of this, and you can access all this on, if you go online, you type in Recover Initiative, you can access all their guidelines. All 7 of these are posted, and they're accessed through JVEC journal from 2012. The clinical guidelines are the 7th section, I think is 20 or 30 pages. So still a good hefty read, but it has everything that you need to know. This first part, 1, evidence review and the process, that's just them going through how they rate stuff, how they grade stuff. The preparedness and prevention talks about how you can do better within your hospital to kind of prep for the possibility of an arrest situation. Basic life support, we'll talk about that. Advanced life support as well. Monitoring, what's useful, not post-cardiac arrest care, goes through a lot more detail than I will. So I think that that's a good chance to review, or something that you can just have ready in case you go through this situation, and you just pull it up after you've had successful ROSC and where you go from there. So come on, my computer's having trouble. I'm so sorry, guys. All right, so when we talk about preparedness, I love this, Mr. T. Some people talk about the 6 Ps, the 5 Ps, the 7 Ps. Really doesn't matter, however you want to say it. I've always said proper preparation prevents piss poor performance. It was what one of the surgeons that I worked with at Tennessee, or actually got learned from at Tennessee, had taught me. But either way, the more we're prepared, the better we're going to have success. And that goes for everything in our lives. So at the veterinary hospital, if we can have a station, that an area that's ready, if we can have the training behind ourselves and behind our team, that will help. Hopefully it's got a note on my computer that said my internet connection will be all right. But I'll keep an eye on that. All right, so big things, if you're organized and you've got a cohesive team, that can really strengthen your success rates within doing CPR on a patient. And that's the big key to me, really. Some other keys to being adequately prepared, and we'll talk about some of these and break them down a little bit further. Having pre-organized arrest stations. Ideally, these are located where animals are anesthetized. At our hospital at Point East, we've got a little triage table, and we have a toolbox is the best description for it. That's right next door to where that is. We've got an anesthesia machine right there. And so we're ready to go in case an animal arrests. Not everyone's going to have a triage table that's going to have everything that they need in it. So ideally, the place where you're going to be anesthetizing your animals is a perfect place to have anything that you need. And we'll talk about what are helpful in those. Other things that I think are very important. I'll talk about this because I think that this is one of the most key places for me, is to do some CPR debriefing at the end. And we'll talk about aspects of that and what are good things to talk about in that, how you can kind of benefit or get yourself on a better track for learning from one arrest event, and improving for the next one. Training programs, like anything, the more you do something, the more easy it gets, the better you are as a team. So any kind of training up is fantastic. And then leadership and communication. So many times we're dealing in veterinary medicine with communication issues where we might infer something to someone, but we don't know if it really gets completed. And so the more that we can communicate appropriately, the better we can have success. And then lastly, for the training programs, practice dummies. And these don't have to be the big dummies that cost $900, $2,000, $3,000. Something as simple as a large stuffed animal, such that it just gives people like them to actually go through the action, go through the motions of doing compressions or anything else. Now, we're clearly not going to be intubating a stuffed animal, but the compressions is kind of a big part of it. And learning how to do that, that's a big step in the right direction. All right, so talking about our crash cart, crash box. We have the crash cart at Point East. Many of the places I've worked at have a crash cart. We also have little crash boxes, which are kind of little toolboxes, kind of like fishing toolboxes, that have just the necessities of what we need. And we've got one in each one of our operating rooms, just in case we need stuff. That way it's close by in the situations where we have an arrest of an animal under anesthesia. So what are important things to consider having in this area or in this box or cart? And clearly, if we're dealing with a box like this, we're not going to have a lot of tubes. And what I mean by tubes is the endotracheal tubes. So you should ideally have one of every size. That's not possible in every single location. But if you at least have one of size 3, 4, 5, 6, and just miss out on the half sizes, that's perfectly fine. Better to have some than to have none. Laryngoscope is extremely important when doing CPR. I consider myself very adept at intubating animals. I can intubate them sideways, upside down, but I cannot do it during CPR without a laryngoscope. Half the time the head's bobbing around as we're doing compressions, and I have to tell them to stop for just a minute to get an animal intubated. So laryngoscope is going to help facilitate that as much as possible. We talked about an anesthesia machine is ideal, or an ambu bag. Ambu bags are just those things that you see on TV where they just squeeze them. They have a mask over a human and they're just squeezing the bag. That's what you ideally need for that. Really, all it is just a reservoir that you can give compressed air or a positive pressure breath to an animal. Ideally tied for a tube. You don't want to put that tube in and you guys are doing compressions and all of a sudden you look over and that tube's sitting on the ground because it fell out of the animal. And that'll be a big key. And that's always something that sometimes gets forgotten or sometimes gets to be tough to find. So having ties for the tubes laying around, monitoring equipment, which we'll talk about at the end. What are good things to have? What are bad things? What are things that whenever you're doing CPR, don't throw away and don't throw off to the side because we don't want them to break because they're probably expensive, but that just are not useful for you. And then drugs. We'll talk about these drugs and what are useful drugs to have and what drugs are not really necessary. All right, the last thing, or one of the last things, is a mobile aspect. So I said that we have a toolbox. It's on wheels. We can haul it around wherever we need to, which is helpful. So we've got a number of different tables that we can sit here and do CPR at, and we can just pull the whole crash cart to where we need to be. The little boxes have that benefit as well. And then one of the last things, is something to write down everything on. And this is something that it really doesn't have to be anything fancy. It can be a blank sheet of paper where you just say, hey, 12:15, we're giving 3 mils of atropine IV, and they holler back, all right, 12:15, note that you gave 3 mils of atropine. ECG rhythm right now at 12:32 is asystole. Just where you can record notes about what's going on, intubated at this time, extubated at this time, started CPR, stopped CPR, intubated with a size 7 tube, any kind of information that you feel like would be necessary. Kind of think of it as like an anesthesia monitoring sheet, but for CPR. That's probably the easiest way to do it. So this is a crash cart that was at another hospital that I worked at. And I like a number of things on this crash cart. So this did have mobility. So it's got the rolling wheels at the bottom. If you look on the bottom right-hand side, I'm hoping that my mouse will show up. This bottom right-hand side is a step stool. Half the people that we work with cannot do adequate chest compressions on these tables, most of the tabletops. So this is a step stool that you pull out, fold down, and everyone can hop up on, or the person that's doing chest compressions can hop up on. We don't need everybody on. Other things that this has is this is a defibrillator, which we do not have at Points East, so it's okay to not have a defibrillator, but it also has an ECG aspect to it where you can hook up an ECG. So it does act as a monitor system, but we usually would use a multi-monitor for that instead. This has suction available, which suction canisters, 2 different ones, and suction lines, and it's also got a number of suction aspects up here as well. Not every place has that, not a big deal. If you look right here, you can see a tourniquet to try to help with including blood flow, whatever minimal amount there is. That way we can get IV access. And then lastly, this is the bread and butter, is these drawers right here. And the important thing that you note on these at least top 3 drawers is there are zip ties that tie off and indicate that this drawer has been stocked. This drawer is ready to go for a CPR, and it'll have initials, date, and time on this for who we hold accountable if something is missing that is not there. So we had sheets that also indicated what we kept in each drawer and adequate supplies of each of those. And so those are important. Lastly, something that I think is very important for people that don't do CPR often or even do it often, but I think is beneficial, is this little black and red device right here on the top of this tray. And that black and red device is a metronome. And that just helps tell us, hey, what kind of pace are we going to do our compressions at? It's so easy when that patient arrests to just get so jazzed up, so adrenaline driven that you might be trying to do compressions at the correct rate and you're doing them twice as much. You're going to get tired twice as fast. Your team's going to get exhausted and the animal is not going to have a benefit for survival. So a metronome is very helpful, and it just makes a click, 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 click sound, or talk, 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 and it's very helpful. So, all right. So breaking down the drawers, this is the top drawer in that particular crash cart. They've got a number of different endotracheal tube sizes. On the left-hand side, they've got a stylet for those smaller trach tube sizes. Intubating a cat when they are alive is difficult. Intubating when they're dead is even harder. So that stylet is extremely important. There's a mouth gag in here, which I don't feel like is hugely important or beneficial. We do have in that little blue tray, there is a laryngoscope there, and that's present. A little suction bulb. And then lastly, on the top right, you see some gauze, which is helpful to hold a tongue. And then there is that capnograph, which says, I live in the crash cart. And that's just a way to monitor CO2 that we found was useful because it was a good place for us to keep it. And also something that's very useful when doing CPR. Second drawer at this hospital was different types of IV fluids and extension sets. Not something that I feel like is hugely necessary to have right next to or within your crash cart. I probably would have unloaded this and put something else in there that was probably more appropriate, but these were perfectly fine. Third drawer down is our drugs, our IV catheter supplies, and a few other supplies. So we've got a number of drugs in here, including some that are not necessary to have in a crash cart, like norepinephrine. That's not technically considered a drug of choice for doing CPR. We do have bicarb in this drawer. There's some naloxone for reversing, epinephrine, atropine, some flushes that are pre-drawn up there in the top middle to right area, some labels with some empty syringes, some IV catheter supplies, and then in that bottom left, there's butterfly supplies. I can't recall a time I've ever done CPR with butterfly supplies or butterfly catheters. Lastly, there's some scalpel blades there in case you ever have to do a cut down to a vessel. So if you're having trouble getting venous access, you can cut open the skin, try to isolate that vessel, and then insert with visualization directly into that vessel, and that might help. All right, third drawer, I think. Is this third? Yeah, maybe this is the bottom drawer, fourth drawer, actually. This is where they kept the ambu bags in here, and they have a number of other things that are really not necessary. They do have sterile gloves, which are helpful in case you ever need to do open chest CPR, which I hope you never have to do. But they also have some other things that include chest tapping kit, which is helpful in case an animal has pleural effusion, a pneumothorax. They've got some sterile gauze in there. Interestingly and helpful for any kind of our ambu bags is that they have manometers on here, which are these green and yellow little spinny looking things on the ends of them. The one downside to these bags, these ambu bags that they have, is that there's not a reservoir plastic bag that comes off the back end here. So technically, whenever we're giving compression or we're giving breaths, it's pulling a lot of room air. Ultimately, room air is better than no air at all when we're giving a breath. But ideally, we would like a reservoir bag down here in the bottom, and then we can hook up oxygen right here such that we're giving them near 100% oxygen when we're giving them breaths. Not a big deal if you don't have one. Anesthesia machines, hopefully that's 100% oxygen. All right, so a little bit about training programs. So what's their benefit? How do we do them? So this is, I used to know the name of this dog, Resuscidog or Casper or something like that. But he has programs that can be hooked up to him and hooked up to multi-monitors to be able to sit here and have simulations for doing CPR and different arrest rhythms per se, different CO2 readings. You can intubate him a little bit, I think about probably 5 or 6 centimeters down, and you can kind of do things with that. So ultimately, training programs, as anyone can guess, practice makes perfect. The more we do it, the better we get. I'm sure all of you can remember your first time you ever spayed or neutered an animal and how horrific it went compared to what you do now. It's ultimately that same concept. So we're trying to get to perfect. We'll never get there, but we can always strive for it as much as we can. The one thing that's very important here is that it develops team roles or team members roles. And this can be anyone from a receptionist, a veterinary assistant, a veterinary nurse or technician, to a doctor. It does not matter what their qualifications are to be able to do CPR. A receptionist can come back and record things for you. An assistant can help by giving breaths. All these people can be trained in different aspects of this. Ultimately, if you look at it, technically, the only one that's allowed to prescribe drugs is the doctor. So that's something that's probably necessary. But whenever I did CPR at Tennessee, I was frequently on with a nurse that was very adept. She had her technician specialty in critical care, and she ran the drug. She's the one that called out everything there. And I just watched people do compressions, and it was great. It was a piece of cake for me for doing that. But there was no pride in it for me. So everyone can help out in some way or another. And it's good to get training done in one aspect of it and then move a member to another aspect. That way everyone can learn how to do each section. And again, back to familiarity with various aspects of CPR. So one thing that I think is important in CPR, and this is where it really leans heavily on us as the doctors, certainly some other people as well for our lead nursing roles, is leadership and communication. Everyone's going to look to that doctor to sit here and say, hey, we got to do this now, we got to do that, and we got to sit here and delegate, because a doctor cannot do everything on their own. You don't want me placing an IV catheter in your animal whenever we're trying to do CPR. I'm really good at them, but I don't want to be the one doing it because there are other people that are better. One big thing with regards to the communication aspect is what they call closed loop communication. And this is something that gets to be, when I explain it, it just seems dumb in a way, but I think it has huge importance. And I really noted this one time when Dr. Brady was running a CPR code, and I was standing back, I was watching some other aspect of it. Again, no pride in CPR. And he was calling out, hey, let's go ahead and give 3 mils of atropine. And then it was just silent. And then 2 minutes later, I was like, hey, did anyone give that 3 mils of atropine? And everyone kind of looked up, and the person was just like, that drew it up was just like, I drew it up. Well, no one knew anything else. And that closed loop communication is the big key. So what that means is I will sit here and say, hey, I need 3 mils of atropine given IV. And the person that's pulling up drugs goes, pulling up 3 mils of atropine IV. And then they hand the drug to someone to give. And they're just like, here's 3 mils of atropine, give it IV. And that person that gives the drug say, just gave 3 mils of atropine IV. And then the person that's recording then says, all right, recorded 3 mils of atropine IV at 12:20. And it gets to be a lot of talking that way, but that way in these stressful situations, everyone knows exactly what is going on. There's give and take from every individual with regards to what's going on. And that's a big key in these situations. Ideally, you have the opportunity to have someone that's doing basic life support evaluation, and then someone that's also leading the advanced life support. That is not always the case. Many times it's just a doctor, a nurse, and an assistant, and everyone's got to do everything. And then you got one person that's doing the advanced life support and basic life support, hopefully together, and maybe doing compressions all at the same time. If you got a team member that's that great, that's fantastic. I have certainly done it that way. I prefer not to, but if we have more team members, I try to get everyone experience in different aspects of things. All right, so the practice dummies. It's sad for me to say we don't even have a practice dummy at Points East. Dr. Harrington and I keep discussing it, and then we just keep forgetting to come back to it and actually order one. But there are a number of dummies available. Again, I think this one here on the left side of the screen, I believe its name is Resuscitadog or Ernie or Bert. I really don't know. He also has a little bulb syringe down here where you can give pulses, and you can feel for normal pulses in him. He's got a fake vessel running down here where you can practice placing IV catheters. Casper here, to me, it's a rubber dog. He's a little bit more creepy to me. They're always creepy no matter what though. And it just feels more awkward because it's less flexible to me. And so I'm not the biggest fan of him, but he has a name developed just like the recovery guidelines where he is CPR in his name, and that's how they came up with Casper, because it can spell CPR with a few letters in the middle. There are many other ones as well. I believe Casper, last time I checked, is like a $900 dog. The other one is somewhere around a $500 or $600 dog. That was before COVID and exponential price increases, so I have no idea what they are at this point. All right. So next up, debriefing. This is the part to me that I always took a big role in as a resident, and I try to take a big role in where we're at now. Sometimes I don't have this opportunity to do it with the team. But to me, I always saw myself as a leader within the team, and I had to sit here and guide everyone. CPR is extremely stressful for all parties included. It's just terrifying. And many times it's with a patient that you've got some kind of commitment to it. And so it can just tear a team apart emotionally, physically. It's just draining. And so the big thing that I would always tell students during my residency was take a break. We've got everything after a CPR. Take a break, get some fresh air, and then let's talk about how we did and what we can do better, and let's learn from this. And I would always do the same thing with our nursing team. Hey, great job. Pat yourselves on the back. We didn't have success here, but I'm really proud of how you guys did. And even if it was terrible, I always try to pat them on the back, because there's always something to be learned. There's always some kind of benefit in it.
I'm gonna go pee and then come back to the table, okay?
Uh-oh.
Hey, Mike, we have a question. If now's a good time.
Yeah, absolutely.
Right. So we have a question coming in that is asking about numbers and how to manage CPR when you're limited to, 3 or 4 staff members in the hospital per day. So, kind of a solo practitioner with minimal staff, any tips for them?
It's so hard. It's so hard. And ultimately what I would say is if all the other patients in your hospital are stable, which hopefully they're more stable than an animal that's arrested, is that patient that's you're about to do CPR, you're doing CPR on, should have everyone's attention. And I would hope that any kind of clientele would also understand as you pull someone from your reception team to come back and help too. And it is so tough to kind of have an all hands on deck. Some people have alarms in their buildings to just push an alarm button and everyone just congregates and runs to where you do CPR because that's where it's been established. And I think this is where the training programs really help out, is if we can sit here and say, hey, we understand we've got 3 people here and you can do CPR with 3 people. We've actually had a debate at Points East. Dr. Kimberly Barth actually says once the CPR gets started, at that point, you really only need 3 people. You need someone to be able to call out drugs and record. You need someone to do chest compressions and someone to breathe. And they can all rotate through different aspects of the CPR, but you really only need 3 people once you get onto cruise control. It's that freak out moment though, for getting IV access, getting them intubated, getting them hooked up to the anesthetic monitoring equipment. That's really the tough initial part. Once you get that part done, you really only need 3 people. And so it's hard, but the more you work with it, the more you talk about it, the more likely you're going to have success with getting that rhythm down. The challenging thing about some place where we work, like Points East, is that I don't always have the same team members. We're open 24 hours a day. I've got the same team most Mondays and Tuesdays, but not always the same on a Thursday or Friday. And those are the days that I work. And so it's tough to kind of develop that role. But if everyone knows the different roles, that's a huge help, because then people can kind of just fill a hole wherever they see it fit. So it can certainly be hard. You just got to continue to hang on. And the more you talk about it, the more you experience it, the more you practice it, the easier it's going to become. All right, so more about the debriefing. My favorite part, again, a chance to regroup after the CPR event. And this can include everyone on the team. It can include just the doctors. It can include just the nursing staff. The more you do things together as a team, the better you're going to trust each other in these situations. So I would include everybody that you can that was involved in the CPR event. Even the people that were standing in the back room watching the boarding animals, but looking through the window with these big old eyes, just terrified of what's going on. Bring them in, because they can help next time. So talk about what we did well. What could we do better? What did we just do terribly? And it is, again, I've said this a couple times, but I haven't made it a big point. There is no pride in CPR. I do not care if I'm running the code, Dr. Brady, who's a surgeon, running the code, or one of our nurses running the codes. To me, it does not matter. It's all about that animal and how can we be better as a team next time? How well did we communicate? I've talked about that closed loop communication, and that's how key that is during CPR. How well did we record this information? What can we do to try to improve for next time? And again, what kind of hinting back to that 3 or 4 person team in the hospital, what were our roles? Did we fill them appropriately? How can we fill them better in the future? And this to me is a big key. The practice, and debriefing whenever it happens are big keys. So, all right. So I didn't talk about this, but whenever we're doing CPR, we're doing them on an animal that's undergone cardiopulmonary arrest, or CPA, just like an accountant, right? So how are we going to recognize it? See, we don't have any questions right now, right, Dr. Brady? All right, we're good. So how are we going to recognize an animal that's undergone an arrest situation, or CPA? We're going to look for 3 different criteria on these animals. First one, an unconscious patient. You will never find an animal that is awake and dead at the same time. Not possible, right? So we're going to lose consciousness. We're not going to have that blood flow to the brain to be able to have that conscious awareness of everything going on. Next, we're going to be looking for is changes in our breathing. So do we have agonal breathing? Everyone knows what that is. God knows we've experienced it too much. Or are we just plain apneic, so not breathing at all? And then lastly, what kind of heartbeat or pulse do we have? And this is the tough thing. And this is the thing that you can't just look at an animal to be able to figure out, right? You have to feel, you have to listen with a stethoscope, feel for their heart beating on their chest, or feel for a pulse. And this can be a little bit tough. One of the big keys is when you're trying to recognize CPA, you should do it within about 15 to 30 seconds because time is important. But make sure that you do the best job that you can to recognize it. So I would hope that these would pop up as we go through these. But top right image is an unconscious man, and then listening to a dog or feeling for pulses, it evaluates that 3rd criteria down there. So, but they did not pop up as the criteria came along. That's all right. All right, so now we've recognized CPA in an animal. Now, what's our next step? What are we going to do? Dr. Nystrom, help us get from point A to point F. How can we get there? The first thing and the most important thing, the only thing that's been proven to be key in successful CPR is basic life support. Everything outside of basic life support is just extra. And what we're talking about here is the ABCs of whatever you want to call it. So in human medicine, they had actually taken a step back and talked about CAB. And we'll talk about each one of these: airway, breathing, and then circulation or compressions. In veterinary medicine, we haven't made an adjustment to say anything other than ABC. And ultimately for me, whenever we're doing CPR, someone's starting the compressions while someone else is trying to get the airway accomplished. And so it's kind of a fluid aspect of everything. But if you talk about doing bystander CPR in humans, they often teach, at least a while ago, I thought that they taught doing compressions first, then achieving an airway and breathing for a patient. And the reason for that difference in humans versus veterinary patients is in many humans, we have grown accustomed to our diets that don't make our hearts very happy. And so what happens with that is that in humans, they are more likely to have an arrest related to cardiac disease. And so that's why compressions are going to be more important. In our veterinary patients, we might be more likely to have issues related to a respiratory arrest in our patients. So there's a little bit of difference there. Ultimately, doesn't make that big of a difference when you're actually doing the CPR itself. Kind of flow with all of them all at once as quickly as you can. Key recommendations here for doing basic life support: rapid recognition, ideally less than 30 seconds. If you can't identify a dead animal in less than 30 seconds, we need to work on what looks dead and what doesn't look dead. Again, these are things that your kennel workers can do. These are things that nurses can do and doctors can do. Potentially even our receptionist as well. So again, there's 3 things: unconscious, not breathing, not having any heartbeat. Immediate initiation of compressions, intubation, and ventilation. There is, I believe I found one study where they evaluated the negative effects, or maybe there's more than one study in human medicine, the negative effects of starting CPR and starting compressions in humans that were not dead yet. So let's say these patients were unconscious, they looked like they weren't breathing, tough to find a pulse, and you just start compressions. I think there was less than a 0.3%, less than a 0.3% occurrence of negative side effects by starting CPR and then not needing it. I cannot count on my hands and toes the number of times that I've started CPR on pets, and then we go to intubate them and then they chomp down on us like we're were their next meal. And all of a sudden they pop back up and it's like, what is going on here? This doesn't make any sense. But we had started compressions on that animal. The worst that we probably did, maybe we broke a couple ribs, maybe we caused some pulmonary contusions, but that animal is alive and we didn't take more than 30 seconds and we were hopefully optimizing our chance of getting a successful ROSC in that situation. The last thing, 2-minute cycles is the recommendation. So when we're doing chest compressions, we do them for 2 minutes, and then we get someone else up there to do compressions for another 2 minutes. If you can't hit 2 minutes, no pride in CPR, not a big deal. Get someone else up there. We're not about anybody but the animal at this time period. The other thing that's going to be helpful is how you're doing those compressions. And we'll talk a little bit about that once we get down to that aspect of CPR. All right, so achieving a patent airway in patients. So this is the A. We're going to need what we already talked about, endotracheal cuff or endotracheal tube with a cuff, so that we can inflate it and get positive pressure ventilation, laryngoscope, secure that tube with a tie. And ultimately, I hinted at this earlier, but you may need to stop doing CPR to be able to intubate them. So ideally, take less than about 10 to 15 seconds to be able to do this. Sometimes it's tough and you might have to take a longer time period. It's not uncommon for animals. Let's say a hit by car shows up to your hospital and in arrest shortly after arriving. They might have a lot of secretions or hemorrhage in the back of their throat. And so have something ready to be able to swab their throat and be able to intubate them. Gauze to hold the tongue. That way you can not have to have it slip out of your hand the whole time while intubating. That's going to be very frustrating for the person that's actually throwing the tube into the animal. Breathing. So how many breaths are we going to be giving these animals? Ideally, we're going to give about 10 breaths per minute. So that's about a breath every 6 to 10 seconds. If you just want to look at a clock and just say, hey, receptionist, or hey, kennel staff, give a breath on every 10-second time period here. Very easy to do. The challenge is whenever you're not paying attention to a clock or you don't have one right there to look at, is you're giving breaths and you're sitting here bagging because your adrenaline's rushing. You're just going for it. I did CPR with it was a anesthesia doctor, not an anesthesiologist, but she had lots of experience. And I did CPR with her one time. And I look over, and this was during my residency, and she's just bagging the snot out of this patient. I was like, yeah, you got to slow down just a little bit, take a deep breath. And we had great success. We got that patient back. We recovered and went home. It did great. And that was the first time that she'd ever had successful CPR event, which I was so happy for her. But that adrenaline hits and you just keep going. And there's no telling how fast you're going with everything until you have someone call you out on it. This is something that's hard to predict. A tidal volume of 10 mils per kg. What does that mean? That means absolutely nothing to me unless an animal's on a ventilator. So you just kind of give a breath until what you feel like is appropriate for that size patient. Now, if you're using an ambu bag this size on a little 2 kg Yorkie, probably not going to compress that bag too much. But if you're using that size bag on a Great Dane, probably going to need to give a larger volume for that Great Dane. Ideally, an inspiratory time of 1 second. All that means is whenever I squeeze on that bag, and I let up. I'm not squeezing on that bag slowly and then letting up. I want to give it over 1 second and then we're done. And then we let off of the animal. Because ideally, we don't want to be breathing too long for that cycle or too much, because the more that we breathe for that patient, the more time we have with increased intrathoracic pressure and the decreased blood flow we get back to the heart. And that's the big key. So too many breaths, bad blood flow back to the heart, bad situation for the animal, not helpful. All right. So what can you do if you cannot or you are unable to intubate an animal? So let's say you get a dog that has locked jaw. How can you give them breaths? What are your other options? Or you're out in the field and someone's dog arrests at a park and you want to do bystander CPR on them. What can you do for them? There's a few different options here. I'm not saying that one is more right than the other. I'm just curious about what you guys think are other options. And unfortunately, there's more than one option that is correct here. All right, hold up oxygen to their mouth or nose, mouth to snout for about 41% of you guys, bag mask ventilation for 30, and then nasopharyngeal oxygen line. Yeah, so this is a tough question. And until you've actually been through it, it's tough to know what you would do in a given situation. So we'll talk about a few of these. I'll come back to this slide just that way I can loop back and then go over why the others that we don't talk about would not be effective. So what can you do if you can't intubate? Mouth to snout breathing. Hopefully my pictures aren't popping up in the right order. I apologize. You can also do bag mask ventilation. So when we talked about mouth to snout, that's what this beautiful picture has illustrated here. You really need to hold the jowls or the lips of that animal closed. And this is whenever you're giving CPR to a human, we pinch the nose and give a breath into the mouth. Well, in dogs, their mouth is so big, we can't cover up their mouth with ours. So we pinch their mouth and then we give a breath through their nose, and that's called mouth to snout ventilation. Bag mask ventilation, I can't remember if I have a picture in here with it. Let's see. Looks like I don't. Bag mask ventilation is, we all have the mask that we can just give flow by oxygen to, many of us do, that black bellows that's on it, or that black rubber seal. If you put that over top of an animal's muzzle and you got to get their nose involved, you got to get their lips completely into there too, and it's got to be nice and snug. And then you can give them a positive pressure ventilation with the bag. And hopefully that will be similar to this mouth to snout situation where you're giving that positive pressure ventilation and it'll get down into their airways. So the other two, we'll go back to the prior slide, the other two, the holding up oxygen to their nose or mouth and then placing a nasopharyngeal oxygen line. The reason why those aren't effective is that these animals are not breathing actively on their own. Remember that they're apneic. So holding up oxygen to their nose is only hoping that you take advantage of whenever you're doing compressions, moving oxygen in and out of their airway, which probably is not going to be sufficient to be able to get enough oxygen down to their lower lungs and enough CO2 out. Same thing with the nasopharyngeal oxygen line, although I love it and I love the thought of it because you're getting oxygen even further down and into that pharyngeal area and hopefully down into the trachea. It doesn't mean that they're getting enough oxygen delivery to their alveoli to be able to adequately exchange oxygen and bring out CO2. So unfortunately, though they are an option to try and to do something, they're probably not very effective. We did talk about earlier with the ambu bags about with regards to 100% oxygen is ideal. Clearly, mouth to snout is not 100% oxygen, but it's better than nothing. And that's what you do bystander CPR in humans. You do mouth to mouth and it seems to be effective. You know, we talked about 10 to 20% of the time at least. So, all right. So when we do our compressions, see, we're about an hour in. I've got to step up my time here. So I'm going to go a little bit quicker. When we do compressions, we're going to do about 100 to 120 compressions per minute. There are a number of songs that you can sing. We'll talk about a few of those, but ideally you want that compression depth to be about a third to half of the width of the chest. We're going to be doing compressions in right lateral. Ideally, you can do them in left lateral. That's perfectly fine. You can also do them in dorsal recumbency. We'll talk about which breeds we do that in, but a third to half of the chest width. And ultimately what you're doing is you're trying to either compress directly over the ventricle or cause enough intrathoracic pressure change to compress the heart with intrathoracic pressure. And that's why you need to go such a big depth. If you feel like you're about to break ribs, you're doing it perfect. If you've broken ribs, maybe just a little bit too hard unless you're dealing with a small old dog, because those always break ribs, it seems like. And then the other thing is make sure you come off of that chest wall. So if I'm compressing right here and I'm going down, I want to make sure that I come off that chest wall at least just a little bit. That way it can recoil and it's going to help with pulling in air from our endotracheal tube and also pulling blood back into that thorax with that negative pressure as we let up. And that'll help with increasing blood flow back to the heart and for us to be able to push around stuff. Ultimately, the heart is the goal is to get that sucker beating again. And the more blood we can get flowing to that heart, the better. And lastly, just to note, when we're doing compressions, we are maybe at best doing 20 to 25% of normal cardiac output. And that's with perfect compressions. So knowing that number, we're lucky if we get that 6% success rate. I don't even know how humans are successful with 40%. It just seems to not be something that's really compatible with life doing these compressions, and clearly isn't because they're dead, but hopefully something that we can get better with some time. All right. Who sings what song whenever you're doing CPR? I've got one. We got Thriller, Sweet Home Alabama, Bye Bye Bye, NSYNC. Another one, Bites the Dust, Staying Alive, and then Other if you're singing anything. I always end up singing a song during this because I'm the kind of character that likes to keep things I guess, enjoyable and airy and light and kind of spunk up the spirit of everybody. And so I tend to probably joke around inappropriately with these patients. But all right, so we got most people sing Staying Alive. Very good one. About 9% say other, and then another one Bites the Dust. My song is Another One Bites the Dust, and people really hate me for it, but I can't help but be like, hey, this is realistic here. Let's talk about this. I didn't even know Bye 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 by NSYNC was an option, or Thriller by Michael Jackson. I'm gonna have to try that next time, pull it up and start singing it, or start playing it during CPR and just see how well it works. But all right, compression rate songs. There are a ton out there. Dancing Queen is one that it seems like lots of people like to do. I've heard a lot about. What was another one? Hips Don't Lie by Shakira. Woohoo! And then there was another one that kind of caught me off guard. I can't remember which one it was. I think it was a Will Smith song. I might not have put it on here, but plenty of options out there that you can play. And these also will give the beat, the number of beats per minute that you could accomplish with that song. So, all right. Looks like we just popped up with, oh, Baby Shark. Oh, I love it. I did remember saying that. Baby Shark, do, 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 do. I feel like that's still fast. Maybe I just sing it too fast. But yeah, I did remember seeing Baby Shark listed on there as one as well. So, all right, so compression pauses. When are we gonna pause? What are we gonna do? How long are we okay to pause? Ideally, we're only taking pauses for a minimal amount of time, so 10 to 15 seconds. We're gonna do this for switching between compressors because ultimately when we're stepping up and down from a stool, if we're doing that, we don't want people getting stepped on, people catching each other, because us getting injured during CPR isn't gonna help the animal at all. We're gonna do this to check that rest rhythm on an ECG and see where we're at with that. And then we can, but that's going to have to be everyone's hands off of the patient for about 5 to 10 seconds to check and see what the ECG tells us. And then ultimately, if you're a solo person doing CPR, you can stop to give a breath. And they usually recommend 30 compressions on the chest to 2 breaths, and then getting back to doing 30 compressions again. So, all right, so compression technique, we've got 2 different techniques that we can do. We can do cardiac compressions and we can do thoracic compressions. We'll talk about each one of these. First, we'll talk about the cardiac compression method. This is going to be one that we're going to use on cats and small dogs. So dogs less than 15 kilograms or about 30 pounds. You can also use this in dogs with keel chests. So potentially in animals like Salukis, greyhounds, you can potentially do this. And ultimately what we're doing when we do these compressions is we're compressing directly over the heart and hopefully directly over that left ventricle. Excuse me. So here's an example on a horrendously ugly cat. Such an ugly cat. But ideally doing compressions, and you're targeting trying to be over that left ventricle such that you're mimicking the compression of the heart. And there's a few different ways that you can do this. In the A example there, the top one, he's doing it with his fingers on either side of the animal and squeezing like this. That thumb gets to start to cramp and it gets to feeling terrible the next few hours and the next day. I personally like to do B, and there even a little modification to that as well. The big thing that if you've noticed in both of these images is that this individual that's doing compressions is standing at the back of the animal. No matter what method you're trying to use, whenever these animals, you're starting to do this, these animals will back away from you and towards their spine. So standing behind them will allow you to put your body up against them and be able to compress against something. Remember that they're kind of not necessarily keel chested, but they round. So when you compress, you're pushing them caudally as well, or sorry, dorsally, I guess is the better description. This is examples of doing cardiac compressions on a bigger dog. This looks, maybe whippet-like size, but again, a keel chest doing directly over top of that heart. This individual is using interlocked fingers, which is important. The other thing that they're doing is that they have their arms nearly straight with regards to these compressions on dogs. A little bit bent here, which is perfectly fine on the cat because they're less exhausting to do compressions on. But on dogs, you want to ideally get high enough such that you can lock out your arms and then you're compressing with your core. Your core is going to last a lot longer than your arms will. No matter how big and burly the gentleman is, his arms will not last as long as his belly will, unfortunately. So especially on big dogs, pit bulls, Labradors, ideally you really want to use that core. And that's why that step stool is important to be able to get above everything. So the thoracic compression method, we're going to be doing this over the widest portion of the chest, often caudal and dorsal to the heart. You start doing it up here and people are looking at you like, there's no heart there. Why are you compressing up there? And again, this method is taking advantage of thoracic pressure. You're increasing that thoracic pressure and hoping that that causes a compression to the heart. Clearly, this is going to be less efficient than the cardiac method because we're not compressing directly over the heart. And this is why bigger dogs have less of a survival than smaller dogs and cats. And again, so we're going, here's the mouse. We're going to go caudal and dorsal. So ideally over the widest portion of the chest. Sometimes I'm even doing compressions up here where I feel like I'm almost compressing over the liver. So you just have to make sure you're trying to stay close to that chest cavity. Again, nearly straight arms, ideally over top of the animal, and compressing using the core is a big key. Barrel-chested dogs, these dumb breeds that we keep alive and unfortunately cannot survive without us. So these are the English bulldogs, French bulldogs, Boston terriers. They are recommended to do dorsal recumbency just like a human. It feels so terribly awkward doing it this way, and I really hate it. So do what feels comfortable. You can do them in lateral too. Either way, they're not built to survive. So good luck. I wish you well. Sorry for having a negative connotation to these breeds. They can just be very difficult to do CPR on. All right, other thoughts. These are kind of just interesting things. You can do these, what's called interposed abdominal compressions. There's a picture here. So this is on a human. Sorry for gross human stuff. But whenever the person doing the chest compressions is pushing down, the person on the abdomen is off. And then whenever the person on the chest is off, the person on the abdomen is down. And what that does is it acts as a pump mechanism such that whenever we're off the chest, we're pushing and compressing the abdomen and hopefully pushing blood back up to that heart. These are not to be done in animals that just have abdominal surgery, a hemoabdomen, or other abdominal disease. You can also wrap their belly with a towel and kind of bind it. Might be a possibility. No shown improvement with regards to veterinary patients, very little in humans, just something of kind of cool and interesting. Again, these people have nearly straight arms here. They're compressing with their core, very important. All right, so now to advanced life support. Let's see, we don't have any questions. All right, advanced life support. So what are these things that we're talking about? There are people that go through advanced life support. So you say the ABCs and then people go D, E, F, and some other stuff. I never learned that stuff. I think the D is supposed to be drugs, E is electrolyte correction, F is fibrillation. Ultimately, I never cared to remember all that. But what do we need? You know, these are just basics. We'll talk about each one of these individually. Vascular access. Ultimately, we need to be giving these patients something for their CPR, whether it's IV fluid boluses, whether it's drugs. We got to give them something. So there are tons of vessels within our veterinary patients. Hopefully you don't have to resort to this ear catheter here. You can get a cephalic in, you can get a jugular catheter in. It doesn't really make a difference. The closer you can get those drugs to the heart, the better. So a jugular catheter is fantastic. But as long as you got something in them, that's what matters. The big key though, is if we have a, let's say Great Dane sized dog here, and we've got a vessel, a vein in the back leg that we're getting drugs into, if we're flushing that, we got to remember how much flush it likely takes to get all the way up here to the heart, because the TikToker is our target for most of the drugs with regards to it then getting pushed someplace else. So that's a key. So Great Dane, I'm flushing with 20 to 30 mils of saline. For this little Cocker Spaniel, or the cat, you know, maybe 3 to 5 mils would be sufficient. So just take that into consideration as well. So what drugs are we going to use? This is what people mostly concentrate when they're doing CPR. But again, this is not the big key. The big key is basic life support. But drugs that we can use epinephrine and we can use atropine. There is one last drug that I imagine none of you have had many experience with unless you spent time in a specialty hospital 5-8 years ago, and we had more of it, which is vasopressin. It's not currently recommended in the AHA guidelines, so I don't even touch base with it. So I just concentrate on epinephrine and atropine. We do not have vasopressin at 0.6, and I do not support getting it for CPR. All right, and excuse this little typo here. That's supposed to be an arrow. So the goal of using epinephrine is it's going to cause vasoconstriction to the vessels, and that will then increase blood flow back to the heart. Our goal is not to increase heart rate. That heart is not ticking at all. So it does not help with increasing heart rate. It helps with vasoconstriction, getting blood flow back to that heart. Interestingly, the beta effects of epinephrine, and that's the effects on the heart, are detrimental to our patients. The alpha effects is what we're going for with the vasoconstriction. So beta can be detrimental. And the dose that we're giving is about 0.1 mils per 10 kilograms, or 0.1 mils per 20 pounds. There will be a CPR chart that you can gain access to with the recovery guidelines, and you can print out and put on a piece of paper on your wall. You can also order charts as well, which are very helpful. I have a little quick view of it here at the end. And then we're going to give this every 3 to 5 minutes, or every about 1 to 2 cycles of CPR. So remember, 2-minute cycles, right? So actually every 2 cycles of CPR is what we're going to do. I usually will only give 3 doses of this. There is high dose epinephrine as well. It's typically not recommended. It's not been shown to show an efficacy over low dose. Some people will give 2 doses of low dose epinephrine, which is at 0.1 mils. The high dose is 1 mil per 10 kilograms, so 10 times the dose. And some people will give a third dose. And when they give the third dose of epinephrine, they'll give the high dose. Sure, why not? At that point, you've not had success. Hail Mary it. That's all we're doing at that point. But in humans, they've actually found that the higher dose has more detrimental side effects to a human recovering and making it out of the hospital. Has similar response rates to the low dose with regards to efficacy of ROSC. So I'd rather have an ROSC and make it out of the hospital than an ROSC and not make it out of the hospital if I use the high dose. Other drug, atropine. We're going to use this as a vagolytic. So anything that has vagal tone. So brachycephalic animals, intra-abdominal disease, pulmonary disease, intracranial disease, all those have increased vagal tone. But if you think that it could have vagal tone, give atropine. If you don't think it has any vagal tone that could have contributed to this, then don't give it. I try to target therapy as best as possible. I used to just shotgun both of these every single time I do CPR. I've gotten away from that and just gone typically with just epinephrine in most of the patients. This will cause a direct effect on the heart by decreasing that vagal tone. And hopefully that will no longer suppress the heart, causing, if that was the cause of the arrest. So potentially it does have the ability to increase heart rate that way. But again, if the TikToker is not TikToking, atropine is not going to do anything until we take away that vagal tone. And that's the primary purpose of it. Sorry, we're going to give this at 1 mil per 10 kicks, or approximately 1 mil per 20 pounds. So it is a 10 times dose change compared to epinephrine. So ultimately, you get their body weight in kgs. I always do everything in kgs for myself, and I just move the decimal place over. 10 kgs, move the decimal place once for atropine, move it twice for epinephrine. And again, we're going to give this every 2 cycles of CPR. All right, so what reversal agents do we have? What can we give? The big thing is anything that we can get out of the animal system, let's do it. If you think about all the humans that we talk about for opioid overdoses and arrests related to opioids, we are going to be giving, Narcan or naloxone to those patients to get anything that they have in their system out or to combat the effects. So if they're under anesthesia, turn off the anesthesia gas, flush that circuit real good. Try not to pop yourself in the face with a bunch of anesthesia gas, a big old puff of it. If we've given an alpha-2 agonist like dexmedetomidine, give the reversal of the atopamazole. Diazepam-midazolam, the reversal is flumazenil. Any of our opioids except for butorphanol, we're going to give them naloxone too. Naloxone will have very little effects on butorphanol because it is a mu kappa. It is a kappa agonist, mu antagonist. So technically, naloxone is the same thing as butorphanol with regards to its mu properties. So, all right. So let's say you don't have an IV catheter in a patient. What would be your preferred secondary drug route? So what would be another option that you can try to get, or your second line that you would go to if you have no success getting an IV catheter into a patient? All right, we had a couple say intraperitoneal, intracardiac, intraosseous, intratracheal. I like these answers, guys. I think you guys did a pretty good job with this. We'll go over these in just a moment, and we'll talk about what other options we have. Back here. All right, so what drug routes do we have? Clearly, IV is the preferred route. That makes perfect sense. We get into the vessel, we get it back to the tick-tocker for us to compress around and get to wherever we need it to go. If it's atropine, our goal is to get it to the heart, so that way we can reverse vagal tone on the SA node and the AV node, the SA node, sorry. If it's epinephrine, our goal is to get it to the periphery out to those alpha receptors in the vessels to cause vasoconstriction. All right, so our second one option is actually intraosseous, would be the next preferred route. This is one that we don't think about except for mostly for kittens and puppies, maybe some birds. Good luck with CPR on birds. There was a recent report, I think, I forget where it was, maybe AVMA, that talked about successful CPR on birds. I've never had success. I've done it in about a dozen birds and never had success. I just don't think they're made for CPR, really. But intraosseous is the next choice, really, because it is just like a large blood vessel that's in a bone. It takes a little bit longer time for it to get to the heart, so you got to flush with a little bit more, but you can certainly do this. I've done this in a number of adult cats, a number of puppies as well. I can't recall the last time I did it in adult dogs. There are catheters that you can get, or kits that you can get, like this Easy IO gun. I'm trying to remember if I have a picture of it. Nope, I don't have a picture of it. An Easy IO gun, which is essentially a drill where you drill directly into whatever bone you're targeting to try to get in that IO space. Third route would be intratracheal. And if you look at this endotracheal tube here, this actually has a lumen going down the center of it, where you can shoot drugs straight into the lungs. Another option is just using a red rubber catheter. If you're going to do intratracheal route, you have to double the dose of drug and then dilute it up to about 3 to 5 mils to make sure you get it all the way through that red rubber and into the patient. And then ideally, you hit it with a little bit of air behind. So I get a 6 cc syringe. I fill it with about 4 mils of drug and saline and then 2 mils of air. And I make sure that air is the last thing and I shove it in there really fast. And the goal for that is to try to get it to spray into the lungs. The lungs have an incredible absorptive capacity and can certainly tolerate that. The last is intracardiac. Ultimately, you can have lots of detriment by doing intracardiac sticks. You can lacerate vessels, you can lacerate the heart, you can completely miss the goal, which is getting into that left ventricle to be able to pump that drug around. But if you have to, you can give it. There was not a recent report, back in 2013, I believe, a report of someone doing CPR on a cat, and they give intracardiac epinephrine and an intracardiac xenotransfusion with dog blood. And I'm just like, that's so amazing and so crazy. I could never do that. So I've never gone this route, actually. I'm just too afraid to do it. We usually end up getting success with an IV catheter. I have done intratracheal. It is the first thing that I reach for typically. Typically, we can get the patient intubated while someone's trying to place a catheter. I'm grabbing that red rubber out of my crash cart to be able to go ahead and give drugs that route. And then I'll repeat them once I get an IV catheter in. All right, so what are we going to do about electrolyte derangements for hyperkalemia? So these are going to be our urethral obstruction cats, and maybe our Addisonian dogs. We can give calcium gluconate. We're going to give it over about 10 minutes. That's the challenge. 10 minutes. That's a long time. This 0.5 mils per kg is the 10% solution. At our hospital, we're currently using the 23% solution due to a while ago a lack of availability of the 10% solution. So if you're using the 23% solution, give about half that dose, really. So about a 1/4 mil per kg over 10 minutes. That's just a long time to give that. If you have hypocalcemia, again, give calcium gluconate. It makes sense, right? Same dose as well. And then if you have a hypoglycemic patient, so like a puppy, kitten that comes in and then arrests, you're going to give about a 1/2 mil per kg of 50% dextrose, dilute it 1 to 2 with some saline or LRS, and then give over about 1 minute to 2 minutes. Really, it's for those. Those are going to be the big ones that we're going to really talk about. I do not support or recommend giving bicarb, sodium bicarb. I have never given it in my life. CPR is maybe the one instance where I would give it, but it can cause a lot of negative side effects in patients too, with a paradoxical hypercapnia and some other issues that can be detrimental to an animal or detrimental to a human whenever doing CPR. So I don't typically recommend it, so I don't talk about it. Volume replacement. If you've got an animal for us at Point Cease that's been in the hospital for 2 or 3 days, it's probably not needing fluid resuscitation. It's probably fluid overloaded, if anything. But if they just show up to you, they just got hit by a car, guaranteed that animal's going to need some volume replacement for hypovolemia. Vomiting dog, hemorrhage patients, they should all be considered. We're going to give quarter shock doses. So remember, shock dose in dogs is 90 mils per kg per hour. And we're going to, in cats, it's about 60 mils per kg per hour. So we're going to give a quarter of that. So dogs, 20 mils per kg over 15 minutes, cats, 60 mils per kg over 15 minutes. Again, not over 2 to 3 minutes. The faster we do it, the more harm that we could potentially do to that heart. I've seen live animals that I'm giving a bolus to and someone's giving it too fast and their heart rate starts to drop because they're decompensating because it's too much and they can't handle it. So just be careful about that. Ideally use a pressure bag in any bolus that you're giving for a dog that's greater than 300 mils because a pump cannot accommodate over 300 mils in less than 15 minutes. Defibrillation, again, if you have it, we're going to be using this in ventricular fibrillation. I never had the stones to be able to do this until after I got on my residency, and I've done it about 6 or 7 times on patients. You can also use it in pulseless ventricular tachycardia, just kind of wipe that off your brain. But ventricular fibrillation is just going to look like a bunch of artifact. So everyone's hands are off the patient, and you're seeing this that just looks like a bunch of nonsense, potentially ventricular fibrillation in a patient. But if you don't have a defibrillator, what are you going to do? And that's the big question. It's called a precordial thump. This is really cool, but really scary. In humans, they actually recommend a certain height off of the patient, and then you just sit here and you thump them right in the chest in a certain place, and you're trying to target right over top of that ventricle. And what you're doing, instead of using electrical charges to reset the heart and all those myocytes that are just all trying to contract and all trying to send an electrical signal at once, you're using a physical stimulus to do that. You're beating that heart to stop it. And so the thing that you got to remember, I've done this a number of times, but alert your team before you sit here and smack the shit out of a patient. That would not be a good idea. You just hit it randomly and everyone's staring at you like, oh my God, this person has lost their marbles. So just give them a heads up. It feels very awkward. I don't like doing it, but I have done it a few times. I got a question here for going back over the shock dosing for cats and dogs. You may have read it backwards. Yeah, not a problem. Let me go back to it here. So quarter shock doses. So a shock dose in a dog total volume is 90 mils per kg over 1 hour. So 60 minutes. We're going to give a quarter of that dose. So quarter the volume, quarter of the time. For cats, the shock dose is about 60 mils per kg per hour. So a quarter of that. The 60 mils in a cat is just because most cats end up being about 6 kgs. Ideal body weight would be 6 kgs. Most of them are not because we have fat cats in our society, and that's why the 60 mils for that. So sorry for any confusion on that. All right, and you're welcome. All right, so precordial thump, kind of crazy, kind of wild to think about. Has anyone ever performed a precordial thump? I just got a text from one of my colleagues that said, Uptown Funk is also a good CPR song. I like that idea. I like it, keeping it upbeat and everything. All right, so, we got about 7 of you that have done a precordial thump and 1 person that has no idea. It's okay to not have an idea. You'll have to look it up and see what you can find. I've done it 4 or 5 times. And it really is kind of similar to taking the stones to sit here and say, I think I need to defibrillate that animal, is coming up with the stones to say I need to precordial thump it. And it's tough because it's also very shocking to everyone around you and just adds to more of the stress of the situation if you sit here and smack the snot out of a patient or punch right through their chest. The big thing is important to remember, if you're ever going to try it, try to target where that ventricle is and where that left ventricle is. Ideally, you want to hit and drive through a little bit. You don't want to drive through to the tabletop because you don't want to cause a heart to explode. But you want to drive through a little bit such that it's actually going to be something. You don't want to just hit the chest and then bounce off of it because that's not going to do any good. All right. There's a really interesting condition called comorbidity cordis. It's a common condition in young male sports, or not a common, hopefully not common, young male sports, where if you get hit in a particular place, so right over top of that ventricle at the right time of your contraction or your ECG cycle, I'm trying to think of the right words here, that it can cause that heart to just stop beating. And people will fall over, kids will fall over. So more common in boys because they're dealing with hockey pucks, lacrosse balls, baseballs, get punched in the chest in the right time period. But if you get it right here at this interval, right at the start of the T wave, it can cause a heart to stop beating. Absolutely wild. I actually met someone the other day when I did a presentation that had that happen and they survived. It's just amazing. It just blew my mind. All right, so open chest CPR, when are we going to do that? We've got a few indications. If you're already in the abdomen or you're already in the chest, if you're in the abdomen, unzip that diaphragm and reach up there and compress that little heart. Sounds a lot more simple than it really is. If you're in the chest, clearly it is a little bit more simple. But compressing directly over top of that heart is going to be a lot more effective than compressing that chest. In a large breed dog, so technically anything over 25 kgs, you should consider doing open chest CPR. I have not ever done open chest CPR. I have no desire to do it. It terrifies the snot out of me. I did have one time where I actually was about to do it and then the owner decided to stop. So it's just really tough to consider because then not only if you get them back, then you got to take them into the OR and get their chest cleaned out and put chest tubes in. The morbidity associated with it is just very high. So they have pleural space disease, so pneumothorax, pleural effusion, a mass associated with it. So craniomediastinal masses, fractured ribs or a flailed chest because you're not going to be able to compress that chest and get good compressions on the heart. And then technically, if you've not had successful ROSC within 3 to 5 minutes for closed chest CPR. Again, I try not to recommend it, and I don't think it holds a huge value. Times that I've seen it, I have not seen it be successful. This is a demonstration over here from @dove.org. A criticalist that was doing it. This is a patient that was euthanized and it was a Great Dane, and she requested permission to be able to use it as a teaching moment for open chest CPR in a Great Dane. These are rib spreaders right here to kind of help open up things. It is really tough in an animal to get your hands and arms in between those ribs without having rib spreaders and be able to compress things. Ideally, you want to compress from the apex of the heart to the base of the heart, similar to what a left ventricle would be doing is the goal. All right, so what monitoring is useful and what is useless? Ultimately, useful monitoring that we have is a capnograph because we want to target a certain end-tidal CO2. That CO2 tells us how well we're perfusing the lungs. That is the only thing that it tells us. We are not trying to target low values with a capnograph when we're doing CPR. We're trying to target higher values because that tells us that we've got more CO2 coming back to the lungs. Ultimately, if you have successful ROSC and you catch the capnograph at just the right time, as soon as they adequately perfusing all their tissues, that CO2 can jump. I've seen it jump up to 140, and it's just unreal. It quickly comes back down because of how quickly CO2 gets exchanged. But it's very fascinating. An ECG is also useful because we want to check for different arrest rhythms. What is useless? A Doppler. So using that to try to monitor for pulses. And except for on an eye, don't try to do it on an eye unless you're just having fun and trying to challenge yourself. Ultimately, that patient's moving around and bobbing around and trying to check and see if you got a pulse to the eyeball, which is the most sensitive area, can just be challenging. Oscillometric blood pressure, again, that's relying on pulsatile flow, and we're only getting 20 to 25% normal cardiac output. Last thing, pulse oximetry. Same exact concept. Pulse oximetry relies on pulsatile flow, and I could care less how well an animal's oxygenating. We're doing CPR, and all of these devices, the Doppler, the oscillometric blood pressure, and pulse oximetry, are all prone to motion artifact, so they're not very helpful. So when we talk about the capnograph, this is an Emma capnograph. This is the one that was in that crash cart. It's portable, which is nice, and you just quickly hook it up to the tube. Their batteries go dead really fast, though. We're targeting doing a CO2, end-tidal CO2 of 12 to 18. Now, many times we're getting like 6 to 9, 6 to 10 is what we're getting. That's telling us how well we're perfusing those lungs and getting out that CO2. 12 to 18 is really good. If you hit 30, that animal likely has some degree of return of spontaneous circulation. Anything, I honestly consider anything above 22 to 25, likely some degree of spontaneous circulation, which is nice. The lower the value means that your compressions are probably inadequate. Usually what I see is someone comes on board and starts doing compressions and they're doing a great job. CO2 jumps up to 11, 12, 13. And then as they're getting close to that 2-minute mark, it's down at like 7, 9. And I'm just like, all right, time to bail out, man, or woman. It's time to bump to the next person. When we talk about ECG arrest rhythms, we're going to talk about 3 different rhythms that we have. We can talk about PEA, which essentially looks like a normal ECG. These complexes will have a PQRS and T, but they'll be a little bit broader and often a little bit taller than a normal one, and they'll be bradycardic. The big key to this is that unless you put your finger on that animal to try to palpate a pulse, you cannot call pulses electrical activity because it otherwise just looks like a normal ECG. Asystole is what we see on TV, and then humans, and they get shocked and they come back to life. That is not a possibility. It is not a shockable rhythm. That's a flat line is what that is. And then ventricular fibrillation, which we already talked about, is the 3rd arrest rhythm. Let's see, we got another question. Oh no, just a statement. If you have any questions, please enter in the chat. That's what someone was saying. All right, so let's see what else that we have coming up. So, and then ventricular, pulseless ventricular tachycardia. Again, this is VTAC is what this is, and probably has no pulses. But all right, so let's say, hey, we've had success. We did CPR. We got him back. And now you go, oh, shoot. Now what am I going to do? And this is usually where I go, oh, shoot. I did a good job. Now I've got more work to do sometimes, depending on how much I like the patient, which I like all my patients. But really depending on how sick they are for me, because I really feel bad getting a patient back that is on death's door and will likely be on death's door afterwards. And I didn't set that owner up with reasonable expectations, or they just wanted to continue to do CPR because they felt like that was the best thing for their pet. So what are we going to do with these animals after they've arrested and we've gotten them back? The big key here is treat them like they're under anesthesia. Monitor their heart rate, monitor their blood pressure, try to optimize that blood pressure with systolic blood pressure greater than 90 as best as you can. Get their temperature up. There is a lot of talk about permissive hypothermia, and that's allowing temperatures between 96 to about 98 degrees or so is probably fair. So I'm not going to aggressively warm these guys up if they're sitting right around the 97, 98 degree mark. I'll kind of let them slowly warm up. And what that allows is for the brain to kind of continue to come back slowly into its own, and not have a lot of energy expenditure in the brain, and maybe preserve tissue a little bit better. Elevate the head 15 degrees. That just decreases the amount of accumulation of blood flow up in the head, and then oxygen support as well. Ideally not with 100% oxygen for long periods of time, longer than 2 hours, but what can you do if you don't have an oxygen cage? And then optimize their ventilation. So target an end-tidal CO2 between 30 to 45. The lower that we get that CO2, the more we might lead to decreased blood flow within the blood flow to the brain. The higher that CO2, the less blood flow to the brain. Sorry, the lower the CO2, less blood flow to the brain. The higher the CO2, more blood flow. So we want to kind of balance it right in that 30 to 45 range is ideal. All right, let's see, post-arrest care. The last thing, once they're stable, this should be a double arrow here that didn't transfer over. Transfer them to a 24-hour facility for monitoring overnight. I have seen many patients that have had arrest under anesthesia, and they've been transferred to me, and regular vets have done a great job. They've stabilized them. I have the easy job. I put an ECG on them overnight. I monitor their blood pressures, and they do fantastic. I send them home the next day, and I'm supposed to be the hero, and I'm not the hero in these instances. You guys are for getting them back and alive. But 24-hour care for the night is pretty key on these guys. This is a link to the Recover Initiative. Again, you can just search for Recover Initiative online. These are some algorithms. This one on the left is the CPR algorithm. The one on the right is the post-cardiac arrest care. It talks about a number of different things, and you can read up on those as much as you'd like to. This is the drug chart that I referenced. I believe that we have this up someplace in point C. Vasopressin is no longer typically recommended in AHA, so I usually don't recommend giving it. It's expensive as anything. I've never given amiodarone during CPR. An internal defibrillator paddles are really cool, but I've never done it before. I want to. But they have weights in kilograms as well as in pounds up here and kind of what to give, which is fantastic. Very easy, very simplified. So in summary, coordinated team, clean communication. So that closed loop communication is big key. Some place to do it where all the equipment is there and that you know where it is. Take a deep breath. 10 breaths per minute, 100 to 120 compressions per minute, 2-minute cycles. Again, walk out those arms, get above that animal as much as you can. Again, last thing, most important thing to remember, they're already dead. You cannot make them more dead. They're dead. Take a deep breath. Those are very important things. You have the information, you have the knowledge in there. Take a deep breath and try to stay as calm as possible. Thank you very much. You guys will get a copy. I'm going to have Matt send a copy of this email or this presentation, hopefully to you guys in a PDF form as well. I've got one last question, then I'll enter a couple questions. Oh, great. Thank you, guys. I appreciate just a couple people saying thank you. Couple things coming up next month in May. We're going to have Dr. Baruda, who is an anesthesiologist that just recently moved to the area. He's going to do a talk on anesthesia for C-sections with a focus on our lovely friends, brachycephalics, because they're the most common friend that we're going to be doing cesareans on. Fantastic educator, fantastic presenter. I actually sat through a similar talk that he did. Really learned a whole lot from it, and that was me as a criticalist. Love his stuff. I'd love to have him as a available option. I believe he works out of someplace in Durham, maybe with Dr. Hoover, the dentist there, but don't hold me to that. And then coming up in June, we'll have our very own Dr. Ann Hen. She's a dermatologist. We'll come up with a derm topic for you guys that she'll present at the end of June for you guys. Again, you guys will get a certificate with everything in about a week's time period. I'm hoping that I can get also the copy of the presentation to you guys. And if you guys have any questions, please feel free to stay on. We'll stay on for a couple minutes and answer any of those. Thank you guys so much for attending. I really appreciate it. Thank you to Pets for putting this on. I will be. Thank you guys very much. All right, so someone asked about the rule of thumb for atropine administration and frequency. I don't know if there's necessarily a rule of thumb. What I would say is ideally try to target your therapy for that drug because we are treating vagal tone is the big key for that. So make sure that an animal has vagal tone to be able to give it and then give it every 2 cycles. Again, that's going to be the one where we do 1 milliliter, 1.0 milliliters for 10 kilograms or 1 milliliter for about 20 pounds. Thanks, everyone. Have a great night.